Bismillah ar-Rahman ar-Rahim, my dear Vascular colleague. This lecture is about what I have learned from LINC Congress 2023 that was last June. My name is Dr. Muhammad Omar Al-Farouk. I'm a consultant vascular surgeon. LINC 2023 is extremely valuable vascular congress. It's a great source of vascular and endovascular skills, tips, and tools. It covers a wide range of development all over the world. And I used to attend this congress for the past maybe 15 years. And it really have very nice memory. This is picture with me and Derek Scheinert and Professor Assam Ayat. This was in 2010. That was 13 years ago when they were eager to start the Congress. And we did visit the Leipzig University, and we did meet Andrew Schmidt. I hope I can summarize to you the benefit. If you are unable to go to Germany and to attend the Congress, I hope I will get the benefit to you and to share with you what I have learned from LINC 2023. Well, the Japanese experience started to show up. There was very old friend, Professor Warasawa, from Japan. He is a dear friend to Derek Scheinert and Andrew Schmidt. And now there are newcomers. One of the cases that I did like very much, live cases, was from Osaka Police Hospital, Osaka Hospital, which is the second largest city in Japan after Tokyo. This was a case of tibial intervention. Now there is a lot of Japanese sessions, live sessions, goes with the rest of the program. This is the first case that was presented from Japan. You can see the patient age is 89, and 89 in Japan is not unusual. And you can see people of 90 and even more than 100. This is not unusual. He is CLTI case of Rutherford 5, non-healing ischemic interdigital ulcer. And you can see this is the ulcer between the big toe and the second toe, ischemic ulcer. Risk factor is hypertension and dyslipidemic, and the skin perfusion pressure on dorsalis pedis is 26 millimeter mercury, and on the plantar side is 25 millimeter mercury. They always use Wi-Fi classification. So his classification is Y1, ischemia 3, and foot infection 0. So they always, when they present the tibial case, they present Wi-Fi classification. So to remind ourselves with Wi-Fi, Y is wound, I for ischemia, and foot infection. Wound is 0 if you have no ulcer, or ulcer 1, 2, 3. Small ulcer to extensive ulcer. Ischemia is 0 if you have pressure, which is toe pressure, more than 60 millimeter mercury. If the toe pressure drop below 30, then you have T3. This patient is T1, so he is considered as mild ischemia. Foot infection, 0 uninfected, and 3 is severe infection. So this is Wi-Fi classification, which is very important. Now, this is the case. You can see nothing in the SFA or the iliac, and you get, this is anterior tibial, then totally occluded, posterior tibial, totally occluded from its origin. And this is a peroneal. Peroneal occluded in the middle segment with large collateral, and then go down. What is unique in the tibial intervention? They put the tibial intervention when they are working the Japanese upside down. So the foot is up here and the knee is down there. And they use the whole intervention on this. They don't use the straightforward that we are used to it. So this is important. So he started with a wire, 0.014 wire, Asahi guide wire, Asahi Gladius, 0.014, same like V14 that we have, or Benson wire, and he tried to correct the peroneal artery. So you can see this is the knee, this is the foot, and you can see this machine is called Shimatsu. Machine is very good angiographic machine. It is as good as GE, Philips, and Siemens. But it is a Japanese company, and there are few machines here in Egypt, Shimatsu, which is very good. So the first things they discuss, which vessel do you tackle first? Do you go for anterior tibial for the total occlusion, or you go for peroneal? There was a debate. Some people preferred AT. I think what is logical is to correct the peroneal artery, and you try to go intraluminal into this crossing as your first option, which is quite logical because it is easier and the direct perfusion. Some people will say this is a big ulcer between big toe and second toe. So according to territory, to angiosomal defect, you need to correct AT first. But the decision what was taken by the interventionist was to go to the peroneal with this wire. Well, he went into the peroneal, the anterior tibial, and at the end of the anterior tibial, he could not pass through. So at the distal end or the distal cap of the occlusion, he couldn't pass. So what he has done, he went with another wire into the collateral. This is called transcollateral recanalization. But this is very tricky. Transcollateral, there are multiple collaterals, not just one. So you must be sure that this collateral is the one that will end up into the retrograde segment, because some of them, it does not end up in this way, you end up in another collateral. So he tried to pass a 0.014 wire with a catheter, and then he went into the distal part. He injected a little bit of dye, and this is a distal peroneal. Now he started to go retrograde, collateral retrograde peritoneal artery perfusion instead of going into retrograde axis transperitoneal, which peroneal artery, we know that the retrograde axis zone 3 is very difficult. So he tried to do this manipulation. So he peroneal artery chosen as the first option, and then they started to do recanalization to the peroneal, which failed, and then they started to go the transcollateral with 0.014 wire. You can see this is the wire, Asahi wire, Gladius, called MGPN, and this is the wire going retrograde. You must know that your wire is capable to do this curve, because unless your wire is unable to make this curve, it wouldn't bend into a transcollateral, and you can damage the tibial. So you must be sure that your wire is validated or can be used for transcollateral, because not every wire can do that. Some wires are very stiff wires, like Galileo wires, for example, and they don't bend. They can do rupture. So you can see this is the intervention that he used to do, Shimatsu machine. Here is the knee and here is the foot, and he's trying to manipulate to go into retrograde. Now, when he tried to go retrograde, again, this distal cap was very difficult, so he couldn't push through any further. And now he went with the original wire, which stopped here. And he started to do what is called the CART technique in cardiology, which is antegrade retrograde recanalization, or same as Safari technique when used it in SFA. And he tried to do this technique on both sides. You can see this is how he handled the wire, 0.014 wire, always by rotation between your fingertips. Don't push, just rotate, and the tip will do the penetration or sliding. And then he tries to do this recanalization. Now here there are two wires from one femoral sheath. You can put two wire, 0.014 plus a balloon from 6 French. This is quite easy and shouldn't be a problem. If you're using 4 French, you might get sticky. If you put a balloon and 2.014 wire, there might be too much friction, which prevent you from doing this technique. So you can use 6 French sheaths, and at the end to use a closure device. So he tried to do retrograde technique without retrograde puncture to the peroneal arch. Anyway, he failed. Again, he tried the integrate, retrograde, ballooning, and safari technique or car technique from cardiology, and it failed and actually ruptured. When he injected this part, it ruptured. Now, what they usually do in the life cases, if you get difficult situation, you shift into a lecture. You let the interventionist do the procedure as he think is best, and then after he finishes the result, you come back to it. And this what happened. It shows that it was not an easy case; it's a difficult case because this is a tibial artery of someone age 90. So it's not easy to do. It's not a heavily calcified artery, but it is difficult to do. So perforation happened, they shift into lecture. Then when they came back, he tried to use IVUS. You can see IVUS is now used a lot in Japan, intravascular ultrasound for tibial with a probe of 2 millimeter probe in order to see where is the lumen and where is the difficult part. He have done that, and he was able, with the aid of IVUS, assisted to do the recanalization of the peroneal artery. So IVUS is very important to be used. IVUS give you a good result, but of course it is an expensive tool if you are going to use it in Egypt. Then after the IVUS, he used long DCB. This is a long 25 centimeter long DCB balloon into the whole peroneal artery, and he stayed for 3 minutes. And after that, he have shown the final run, which is this one. This is the final run. This is the peroneal, and this is the transcollateral that he already have passed into the main lumen. You can see the collateral did not disappear, still causing some blood, but the main blood is going into the main peroneal artery, into the distal. After that, because the patient was, let us say, mild ischemia, he did not go to anterior tibial artery and posterior tibial artery. He done the minimum to get the patient out of danger, and the DCB will maintain this vessel patent for a longer duration. There is an argument, if you go to critical limb ischemia, you need to do full correction, which is not bad if it does not cost too much money, doesn't not cause too much time, and doesn't have much of complication rate. But you can see the posterior tibial, you can't see the origin, so this is quite tricky. And the anterior tibial artery is secluded from zone 1. So again, it will be long, difficult procedure. So it's quite acceptable just to maintain just one vessel perfusion and keep the patient under duplex surveillance and duplex follow-up. And this was the final angio. So what I have learned from this case, I have learned that 0.014 wire is the standard for PTK. 0.035 is out of the question. You can't use 0.035, not even a try. Now, the transcollateral is a valid option, but it needs experience. You must be very careful which collateral to tackle with which wire. And you can get used to reverse angiogram tibial. So a lot of angio suites we have in Egypt sometimes bring the machine upside down. It's not a problem. You can start learning how to use with an upside down angiogram, both in tibial and in SFA. It's not a problem. IVUS is a luxury for tibial. There is no good evidence to use IVUS. We know that if you have vessel, you think on angiogram that it need 2 millimeter balloon. IVUS will tell you that you need 2.5 millimeter balloon. This is the lesson we learned from IVUS, but we have learned this lesson without using IVUS catheter in every case. But if you have an IVUS, obviously, it's a luxury for tibial intervention. DCB is definitely here to stay, either sirolimus or paclitaxel. Both of them seem to be valid option for tibial vessel. Two wiring technique is very useful. CAR technique is one of the very useful technique, and you can use it from the transcollateral and the antegrade to peroneal artery from 6 French sheaths. And Shimatsu is a very good machine made by Japan. I hope we can manufacture our own angio suite here in the Middle East. Thank you very much. I hope I have shared with you what I have learned from LINC2023, and hopefully over the next few lectures, I will share more of the lessons that I have learned for your benefit and for all our patients. Wish you all the best. This is Dr. Muhammad Omar El Farouk, consultant vascular surgeon.